Okay, Megan, we're recording. We're live. All right, everybody, welcome to the CALU Community Case Study. I'm very excited to be running this one. These are generally pretty fun discussions. I ask if you are not chatting just to keep yourself muted, just for the audio quality for people listening to the playback. But yeah, we try to keep these interactive, so please share thoughts. Based on past flows, I'm going to be trying something a little bit different tonight just to kind of expedite things a little bit and keep it around a true 60-minute, 70-minute time cap. So Grandpa Zak can get to bed at a reasonable hour. But we will definitely be doing at least one good breakout session throughout this. And we're going to be talking about managing low back pain, specifically when people are having radiating symptoms, which can low key be terrifying, especially I think back to new grad Zak. Was definitely very terrified when I had someone coming in with these types of symptoms. So my hope is that this can be helpful, insightful. I'm happy to get some feedback from people in terms of, me just sharing my approach. But first off, so just out of curiosity, because it's always fun to do and break the ice, feel free to get the chat popping off during this little mini presentation and stuff. Just where you're tuning in from in the world, you can just drop that in the chat right now and just let us know.
Ask me to be your girlfriend, and then you can break up.
Drama. All right, let's see. It's always fun to see. Ooh, yes, love. Always got some Australia. The 8 p.m. time works for that. Beautiful. All right, cool. And then from a scale of 0 to 10, 10 being like, ooh, I love, this is my jam. When I see someone coming in with this type of symptoms, I'm super confident and excited to help with managing this. 0 being, oh my God, I'm terrified. Safe space. Just curious to see where people are at with their confidence levels managing this type of stuff. -7. Kevin, I highly doubt that. I highly, highly, highly doubt that. Cool. And the funny thing is, when I say confidence, doesn't necessarily mean like, oh my God, like I'm a wizard with this stuff. It's more of how can we gain confidence in just the overall course of how these things tend to play out. And I think that's been super helpful. So we're going to dive into it. And before we do so, what I want to start actually, before I share some of the context of the case, besides for just like a 36-year-old male recreational powerlifter coming in with low back pain and radiating pain, I guess some of the things that I wanted to talk to you guys about in just a group first is just what are some of the key things that inform our rehab for this type of thing. So it's like we kind of talk about like I love Derek Miles for bringing the cooking analogies, but the mise en place or how we're setting things up. So thinking critically about this type of presentation before we even get into it. So just in terms of having someone come in with this, like what are some important things? And I guess we can start with just reviewing, like, what are some of the major red flags? Like let's just list off some of the red flags. You can put them in the chat or please just unmute yourself and chat. So it's not just me talking. All right. So we got saddle anesthesia, bowel bladder issues. Okay. Anything else? Night pain, history of cancer, pain that doesn't change with movement, pain with coughing or sneezing, fever, night sweats, uncontrolled weight loss. Okay, sweet. Any other ones? Upper motor neuron signs, progressive neurological symptoms. Cool. Weakness in extremities. So I think these are all totally solid and something to keep in mind. And that's just like, those are always on my radar when I'm prepping for these types of cases. Is it's rare when I see something that is truly to this level, but I've had a few over the last 7 years where you end up referring out, but that's solid start. All right. So in terms of, I want to just talk quickly about prognosis for these types of things. So generally speaking, someone coming in with an acute, subacute episode of low back pain with or without radiating symptoms, does anyone know like what is the general prognosis? And then I want to talk a little bit about prognostic factors. And we're just going to spend a couple of minutes here, but I think it's helpful to layer in this context before we get into the case. Adrian, it'll probs get better if you do nothing. All right. So how do we say that differently? Anybody? I know some people. All right. Yes, the natural history, positive prognosis. So, and again, these are some percentages that are thrown around, but generally speaking, to what degree of people coming in with acute low back pain, rough, these are kind of arbitrary in a sense, but rough percentage, what percentage of these are things that are genuinely like medically dire, medically urgent to go get help when people are coming in with these types of presentations? Yeah, we'll say roughly less than 5%. So that's, I think, the interesting thing with this. And I had another case today with an individual who's about 4 weeks into a pretty intense seeming nerve root type of injury. But the fear around it is super high, despite the overall prognosis being pretty good overall. Does anyone know timelines, generally speaking, for acute low back pain, general timelines for when we tend to see people start to recover?
I think it's largely in that like 8 to 12 week mark. Is that correct, Zach?
Yeah, I think that's pretty solid. I think, and this is where, so we talk a lot about like things like regression to the mean and natural history get thrown a lot, especially I know in the CALU circles, but I think it's something that I've probably leaned on a little bit, maybe not as fairly in certain cases, but with acute low back pain and subacute low back pain, I think this is one of the times where it's really kind of like, we really have this in our favor when people are coming in with such high symptomology. Odds are, especially within those first few weeks of acute into subacute low back pain, you're generally on average going to see at least kind of a turning of the corner where it's not so severe and not so intense. And that can be really powerful when you're educating them. I think based off of some of what I understand, it's generally that sort of 8 to 12 weeks. You tend to see improvements within those first 4 weeks, like the intensity drop off. And then again, some of these percentages are somewhat arbitrary, but I think it's around somewhere in the mid 70% of people will have a relatively full recovery within the 12 weeks and full function, maybe not totally pain-free, but kind of doing their thing and not necessarily in need of rehab services per se. Anyone have any like things to add or pushback or challenges to that? I'm totally okay with being wrong. That's just my understanding of it. And again, this is on average. So obviously there's certain contexts and cases where this isn't the case. And then last thing I want to talk about real quick before we get into the case is prognostic factors. So we talked about general prognosis, but what are some other prognostic factors that might influence the likelihood that someone might experience a good natural history and a good, healing time frame? History of low back pain, sleep.
Well, I was going to jump in and say like something like depression or kinesiophobia.
Sure. Yeah. So depression, some of those factors, fear of movement, anxiety around movement. Sure. What else? Self-efficacy. Diet, prior level of function for sure. So like activity history, how active are they? They're meeting physical activity guidelines, socioeconomic status and other social determinants. Yeah. So like, how's their social support? What's their, economic background? Like, unfortunately, these things can play a pretty large role in some of the prognostics. So I think it's good to have a base understanding of general prognosis for these things, but then it's on you to kind of like interpret the situation and understand how some of these factors may play into someone's prognosis being potentially longer or whatever. And that becomes an interesting thing when we're kind of talking about that transparently. But yeah, this is all super duper solid. So I'm going to go ahead and share my screen and we're just going to get going. And the way we're going to do this, we've done it before where basically like I do the subjective and then we do small group breakouts. But I think we're going to stay in a big group for the meat and potatoes of the beginning. And then when we get past objective testing results and we get into like plan of care delivery, that's when we're going to break out into small groups and do role play, because it's really helpful to practice like, okay, cool, we can do all of this stuff. And then how the hell are you actually communicating it to this person in a, cohesive, empowering way And I think that's the tricky part. So I think that'll be a really good use of the small breakouts. So for now, we'll keep things cruising. So I'm going to see if this works. Okay. All right. All right. We cool? People can see my screen? Just thumbs up for people with their cameras on because I can see some of you. Okay, cool. Thank you. All right, so we went through, this is just me organizing my thoughts. So this is makes sense. All right, so we went through this sum of stuff. Ooh, this was one thing we didn't talk about. So we talked about prognostic factors, general prognosis, general rehab approach. Are there any approaches superior to others? So I think this is something that will make for some really interesting discussion, and we won't necessarily get into the nitty gritty, but more or less, the short answer is no. There's really not any approaches that are wildly superior to others, at least to my knowledge. I find this to be a very positive and optimistic thing because I think it gives us a lot of flexibility. I also think it allows us to keep it simple. I'll be very honest with you. A lot of my, kind of approach and bias in rehab is very much informed by Occam's razor. And my understanding of that is if we don't the treatment should make as few assumptions as possible. So I want to provide the best possible care that I can, but if it doesn't need to be overcomplicated in any way that is necessary, I don't necessarily want to do that. And so I find this information about the different approaches at first could be a little bit heartbreaking when I was huge core stability person. But now I find it kind of nice. So we'll chat about that as time goes on, but I want to get in and share this objective. So I'm just going to read aloud. You can follow along. Also, for everyone that came, I have a nice PDF that kind of puts together everything from subjective, objective, my plan of care, as well as the email that I send him. So I'll send that to everyone after this for those that are interested. So 36-year-old male, dietitian, avid gym goer of over 20 years. And while I'm reading this, you're thinking to yourself, okay, what are some salient points? What are things that are kind of sticking out to you? Maybe getting a vibe of some of the questions that I might have asked. So he reports his initial back injury occurred roughly 4 years ago while he was a medic. He reports lifting a patient awkwardly, resulting in immediate low back pain. He went to his PCP, who diagnosed it as an SI sprain and was advised to go to PT. Patient reports he did not get imaging at the time, although he wanted it. Patient did recover decently with time and PT focusing on mostly core stability type of approach, including McGill Big 3 and hip exercises. Patient reports that since then, he's had episodic low back pain episodes, good writing, Zach, that will generally resolve with time and relative rest. It was not until this past late December 2021 that he had a more concerning low back injury after a day of lifting with no real, when I say no real mechanism of injury, I kind of, in my mind, I refer to those as oh shit moments. There was no real oh shit moment where he was like, oh my God, something's injured. Something felt off and it had kind of just gotten worse. A few weeks later, he had gotten sick, and after a violent cough, he felt something tear, quote unquote, in his low back. And since then has felt some left radiating symptoms into his left glute, posterior lateral thigh, and occasionally into the lower leg, but not too frequently. Not too frequently, the symptoms going into the lower leg. Patient reports he went to an ortho who told him it was likely a quote unquote S1 disc bulge with nerve root impingement and prescribed oral steroids. He reports being frustrated that the ortho did not do the MRI and reports wanting to know what is going on. Since seeing the orthopedic 2 weeks ago, he reports that the symptoms have been improving, but is still feeling left-sided low back pain and left radiating symptoms that are aggravated by bending forward, extending backwards, hinging, twisting, and prolonged sitting. He reports he is currently doing a 5-day split at the gym and is relatively tolerating squatting, but is having pain with deadlift variations and benching. Patient reports he is currently sleeping well and denies any other serious red flags. Patient reports he is extremely motivated to return to lifting and hopefully gain a better understanding of what's going on with his back injury and what he can do to improve the recurring nature of his situation. Currently reports his pain at around a 5 out of 10. It's achy and tingling. And again, it's in that left lower back, left posterior thigh to left lateral knee, and it's intermittent. So I'm going to pause there. I know we kind of went through a lot, but in terms of just the subjective, I kind of just we're just going to get a small group discussion for like the next 5 to 10 minutes. What are some of the big things that kind of stuck out to you with this individual, or like, what are some of the big questions you want to ask in these situations? And what were some of the things you gleaned? And maybe we can just start sharing that out loud or dumping it in the chat. Yeah. So he's a young male. He's a gym goer. What about his training age? Small training age, long training age? Long. Yeah. He's been 20 years of training. So that's important information. Yeah, Nate, totally. Repeated frustration for not receiving MRI. And that was definitely a vibe he was putting out strong during the initial encounter. Was like clearly frustrated about not getting the imaging twice for this individual. What else did we pick up from the subjective? What's his overall, like, just from the subjective, like, what does his overall disposition seem like? Does he seem like someone that's scared of movement? Does he seem like someone that's kind of doing his thing?
If he's okay to squat and deadlift variations, it sounds like he's all right to kind of do his thing. But he also threw, like, he knew exactly what happened 4 years ago. So it's not like he's perseverating, but it definitely has like a little bit of like, okay, that's sort of when it started.
Yeah, exactly. And JP nailed it. It's more so concerned with the recurrence of it, just like you kind of said, Christian, but he's not necessarily someone that's like scared to move. He's like, yeah, I'm keep going to the gym and I'm like trying to do these things, but it keeps kind of irritating my symptoms. So that's, I think, a helpful thing to understand is like the type of person you're dealing with. Are they like totally fearful of even doing anything? Or are they kind of just like, I don't know what's going on and I'm just kind of doing everything? Yep. Cool. Good things in the chat. What else? Is there anything else from the subjective that was helpful, or is there any other information that you all would want to know?
I guess just some things like how long does it, like irritability, like how long does it take for that tingling and those sensations to come on? Is it like immediately? Does it go away immediately? Is it lingering? Understanding that better.
Yep. So good question. I think I need to look back to it, but I think he was currently like sitting was around like 30 minutes was kind of his threshold for when he would start to get more of the radiating symptoms. But he definitely reported that it did feel generally better with movement. Like moving was helpful. Any other big questions or things that people would want to know from that subjective? Yep. So Ryan asked, if he has found any specific movements or positions that resolve his symptoms. And like I said, I think he's, besides for tolerating squatting, I don't think there was anything he was intuitively doing. That goes into a really important question, though, is past rehab. So understanding what he's done in the past. So he shared that last time, again, he kind of got better doing like lower level kind of core stability, McGill Big Three. And again, that's pretty unsurprising considering that most people generally get better anyway with low back pain. But again, these are some of the downstream consequences of like, well, what, you know what I mean? Like, what's the consequence of those narratives? Now, if someone's really caught up on like, is this a core stability issue? And he was also very much like, during the subjective, he was also very forthright about like, I don't feel like I can brace properly on the left side, and like other little muscle quirks that he felt were off, things that he kind of felt were off. So, and the gym that he goes to is a gym that I work with a lot that is very much like very, very kind of biomechanical with their pain philosophy. So also knew that kind of going into it. Cool. Yep. Ask him, what he defines as successful outcomes. What types of load is he squatting? Yep. So Corey, great question, because knowing what his previous kind of bests are is going to inform some of our progressions as we get back into it. Because if he's easily squatting and pulling over 400 pounds, then once he's tolerating things, we might not necessarily need to be like super babying stuff. So that's a good point. Cool. All right. Is there anything else? I know we kind of breezed through that, but we can certainly chat more about it if anyone has any questions. Yeah, current programming. So he's working with a coach who I know well, and he's kind of doing a hodgepodge of like a 5-day split. And we'll chat about that later. I ended up kind of working through it and modifying some things and how I ended up managing his care. But I think that's good. That's solid. So let's keep it moving for the sake of kind of getting through the objective, because I think it'll be really good to do the breakouts and then share kind of how this was all managed. And feel free to just keep asking any questions that you have in the chat. But let me see if I can pull up. I don't know where. Sorry, guys. Just bear with me. All right. All right, cool. So this is my objective testing sequence that I go through. Again, these things can be tricky, especially if someone's coming in with more intense pain. There's only so much that you might actually want to work through for objective. But given the fact that he's squatting and doing some of these different things, I felt good to kind of work through some stuff. So super simple lumbar screen always. Both his patellar tendon and Achilles tendon reflex were totally normal and symmetrical side to side. His quick myotome screen was unremarkable side to side. Same with dermatomes. Flexion, again, these are pretty rough percentages for documentation purposes. So we'll say flexion was limited pretty significantly with symptom provocation. Extension was also, it wasn't as limited, but definite symptom provocation. Rotation and side bend both felt pretty fine. From my range of motion screening and standing, I'll generally go to sitting for slump testing. And based on his subjective, I had a pretty high likelihood in my head that I thought there would probably be some neural tension, just based off of his intolerance for flexion and deadlifting and things like that. And sure enough, that was pretty significant in both his slump testing and his straight leg raise testing. So even on the right side, it was recreating symptoms at the end of his right slump test, and then left at around 70 degrees of knee flexion was where he was getting symptom reproduction. And I think that's something that I've definitely found myself doing more of with these sorts of radiating pain and people with neural tension symptoms, is just making sure I'm documenting where they're at. That way we can kind of use that as a KPI in phase 1 of like, is their tolerance for dural tension improving? And then after that, I just do a simple like cat-cow. Can they tolerate cat-cow? Can they tolerate rock backs? Again, like someone that's coming in with flexion intolerance, but they can do, a cat-cow and they can do rock backs. Boom. We already have an entry point into exposing them to some lumbar flexion, which is a beautiful thing. And then the hinge was super painful and very limited. Like he did like a baby hinge and he was like, ooh, yeah, like that was it. So that was basically the extent of my testing, given I knew kind of what his programming had looked like over the week, that he was squatting and doing that stuff. Felt like I didn't really need to see that much more given where he was at. So keep in mind, I think he was around 4 weeks out from the injury seeing me. So I felt like where we were kind of in a good spot. So what I want to do now, I think, okay. Okay. So here's what we're going to do. So as a group right now, just from an objective testing. So is there anything else that you would want to do from an objective testing perspective? Nothing right, wrong. Feel free to push back on me. If there's anything else that you would have wanted to do, like, please feel free to share.
I would have maybe done a mid-thigh pull, like an isometric mid-thigh pull, if he didn't jump through the roof on the initial hinge. But with that, probably not, I would say.
Fair. Anything else? Do you guys feel like that was a thorough enough objective testing for this individual? Because I guess that's always kind of the art, is figuring out like what's enough, how much testing is sufficient. And even with these, and that's what's super interesting, is like even with these cases, it's like could probably have done this fully virtual and have a really good understanding of what the hell is going on and how you're going to manage it. So I felt pretty clear on some patterns and things that was kind of emerging from that. And so Anna asked, do you do any accessory movement tests in sideline? So do you mean like a sideline, like hip abduction test, or like a side plank? Anna? Okay. I will. So if for folks that aren't super volatile like that, I generally will do some basic like core testing, just from like it's an easy KPI, and it also gives you an idea of their attitude and disposition towards using their back. So is it something that they are comfortable doing? How long can they do it for? Easy way to just kind of get things going. But yeah, based on the subjective and based on the objective testing, like generally speaking, what do we kind of think is going on? Okay, so here's what we're going to do. We're going to break out. We're going to do rooms of 6. And what I really want people to do is, first, as a group, we're just going to do 10 minutes. So as a group, you can kind of chat it out for like 2 minutes if you want, but I would challenge you to get right into it. Someone volunteer to be therapist, someone volunteer to be patient. Knowing the subjective, try to get into a role. Okay, so you can channel this person and be this person to make a good mock role play scenario. And then we'll reconvene in about 10 minutes. I'll share some of my thoughts, and I will share how I broke it down to him, the email correspondence that I sent to him, and then the game plan and what the first week of plan of care looked like and what the following weeks looked like, and how he's doing current today. Does that sound good? All right, cool. Let's see if I can get this. Ooh, Megan. Hello, friends. I don't know if I'm able to do.
I made you the host, so are you?
It's in more now. It's not its own thing.
Oh, interesting.
Okay, let's go. And Megan, if you're able to, could you help with like if people get kicked out, could you help assign them to other rooms?
Yes.
All right, cool. All right, guys, see everyone in 10 minutes. Have fun. All right, let's go. Who's stepping up to the plate?
We're like continuing with the eval?
So we're basically like based off of, I think first we can touch base really quick, like based on the subjective, based on the objective testing and what we kind of identified, you're basically trying to communicate like, okay, here's what I think is going on. Here's what I think would be a reasonable starting point. That's what we're looking for.
Okay.
So does anyone feel brave enough? Rachel, that's a very good out. There's literally no judgment zone. This is the place to do it.
I guess I would start by like saying your body just might not have like a tolerance for certain positions right now. And we just kind of have to like ease it into like accepting or like being tolerant of those positions, like little by little. And I would say generally, like when I work with a patient with low back pain, I try to just see that each day, like it's a little bit different. Like I try to see like which movement they're tolerating more today and kind of just go into that movement. Because if you strengthen in a tolerable position, like generally the whole back like might start to feel better. So I guess I would start with that, like just saying like we're just gonna kind of ease into motions.
Okay, fair deal. So let's say I'm the patient now, so you can kind of like talk to me as if we're like in clinic. So all right, that all sounds good, but what do you think is actually going on with my back?
Okay. Well, I think that there might be it might be just like a flare up of something that's been happening before. Maybe you have like some irritation to nerves that start in your back and like go into your, I'm talking to a patient.
Yes, talk to me. I'm the patient right now. Yep.
So nerves start in your back and they go into your legs, and sometimes they can become a little bit irritated. But if we just kind of like get them into positions that are like a little bit like natural positions that like you used to be able to do, they should get like a little less irritated.
Okay, that sounds good. But yeah, so the doctor was saying that there's probably some sort of disc injury in my back. Do you think that's the case?
Well, so honestly, like it could very well be that you have like some sort of injury, but if you like these things are like super common. If you like take a random image of someone off the street, like they could have something similar going on. It's very common, and we can just kind of ease you back into things.
Okay. So what's the plan for like, what do you think we should do for like this next, like these first couple of weeks? Like what would that kind of look like?
These first couple of weeks, we're going to explore movements. We're going to see like which functional things you can do, like anything that you can really tolerate. We can do back movements. We can even look at like what your legs and what your arms can tolerate, and we'll go from there.
Okay, cool. End scene. All right, cool. Emma, good job. Good job stepping up to the plate. It's super awkward doing these things, but is helpful. All right, so do we have any feedback from the squad in terms of like anything that you might have done a little different or same, whatever, things that went well?
I thought that was really good. I definitely think it's important that we educate patients. I think we have to stress like not necessarily like hurt doesn't always mean harm. You might be in a little bit of discomfort when we do certain exercises. However, you might not be doing any other further damage to what is already done. I also think it's important that to kind of change that language with like doctors always say like, oh, well, you herniated a disc. Well, that's not a death sentence. Like we can get you back to where you were prior to that injury with some rehab. And you just have to kind of trust the process and take it day by day.
Sure. Love it.
Yeah, I agree with that. And like what both of you said about educating them on that, not everyone with the herniated disc is like, that's the cause of everything. You're not what your MRI shows. Just because it shows you have something doesn't mean that's exactly what the cause of the issue might be.
Fair. Yeah. And I think in these cases, it's tricky because he was very adamant about wanting to know his imaging. So that's why, Emma, I was kind of pushing back on you because, you know, and I think that's also, we talk about it a lot, but like, it's okay to talk about image. It's okay to talk about structural things. I think the biggest thing is, Gabby, you kind of nailed it in the sense of it not being a death sentence. And I will drop like Emma and Dom, like I'll talk about imaging studies here and there, but I actually think for this person, the more relevant piece of education is that the prognosis is really fucking good. Like, even if there is that, like, even if you do have any sort of disc injury or disc pathology, the overall prognosis for this type of thing is really, really good. These things can heal on their own. We know that we want to start to find tolerable positions, like you said, Emma. And so that's sort of the route that I might spin it on, is really like trying to hit home that narrative.
Sometimes I've had patients like this before, and I'm just like open and honest with them, and I'm saying, or I tell them that yes, imaging can help provide sort of like a peace of mind kind of thing, maybe point to what's going on, but ultimately the good news is like we don't have to exactly know what's going on, as long as we can find like comfortable movements and we start to see a response to it.
Yep, super solid. Gabby, you were saying something?
Yeah, in school, some professors still like to use the jelly donut.
Oof.
Yeah. Is there a better way to kind of explain to patients like the anatomy, but kind of in a dumbed down way?
Yeah, I mean, that's definitely something, like, I'm fine with talking about anatomy and like pathology and things like that, but I generally won't get into the nitty gritty of like the structure of the disc or things like that, you know. And like I is it Kaylin?
Mm-hmm.
All right, cool. Like Chaylin said, like, I think in these cases, you need to be honest, because we're saying like, we don't know for sure that it is a disc injury. We're just saying, sure, like it could potentially be, it could just be other, like it could be nerve tissue that's irritated based on your symptoms. We don't necessarily know exactly, but we know that majority of these cases tend to resolve over like the course of 8 to 12 weeks. You have a lot of things in your favor that you're already doing that bode well for that. And we've already identified some key patterns that are going to inform our starting process. So we have a lot of information to get us going. And it's tricky, right? Because we know that imaging can sometimes be a negative prognostic factor when people end up going to get that with low back pain. But with this person, it's a tight rope to walk, because like he really wants it. So I don't want to dismiss that, but also try to explain where the medical profession comes from in terms of not, because he was like, were they in the wrong for not doing the image? I'm like, technically, it's actually kind of the right thing to do. Like, I know it's shitty, but it wouldn't radically change the way we're going to manage this, even if we were able to identify that. But yeah, he just really wanted the peace of mind. All right, we're closing in 60 seconds. So any final thoughts before we go into it? Yeah, so I'm about to share my whole spiel, and basically you can kind of follow along and be like, oh, cool, those are things that I do, or oh, that's pretty shitty thing, I'm not going to say that, or anything in between. So I hope it's helpful, but I also hope it serves as a way for you to reflect on your own narratives, because these things, like, we kind of know the knowledge, but then when push comes to shove and we actually have to talk to people about it, it can get a little bit dicey. So I think it's always good to just reflect on those things, but you guys did great. And this was a fun group. So appreciate y'all.
Appreciate it.
Yeah. I think we did. Oh, good. Let's see if the timing works. I feel like we're about to get sucked into the vortex real quick. All right, so if everyone had as much fun as our group, then I think that was a good time. Did you guys have fun doing that? Yeah, it's good practice. It's like easy for us to talk about the nerd stuff behind the scenes, but then when push comes to shove and you actually have to have a conversation about it with patients, it can get a little bit tricky. So what we're gonna do, just for time's sake, is I'm gonna roll through kind of my spiel. I'll talk about just like the email that I sent, and that kind of just synthesizes some of the key points that I want to get across. And I was saying to my group, like, you know, this is just my way of doing it. As we know, with managing low back pain, a lot of these things, there's a lot of flexibility in the approach. And I think if nothing else, hopefully this will serve as a good way for you all to kind of reflect on what are your own narratives, or what are some of your own shticks that you end up utilizing in these types of things. And for better or worse, maybe you take some things that you like, maybe there's things you don't like, but we'll go there. And I kind of want to just go through all of that so we can just leave the last like 10 minutes for just open Q&A to talk about the good, the bad, and the ugly with how I manage this case. All right, we good. Okay, so, all right, so keep in mind that this was someone, again, we kind of talked about this in my group. This was someone that was really pushing to know about, like, what do you think's going on? What structural things are going on? And I was talking to my group, and I've like to think I've been on record now enough saying like, it's okay to talk about pathology and structure as long as we're framing it in a bigger context and kind of nailing in on some of the uncertainty about it and the prognosis of it. So this was, and I'm just going to read it out. But this was kind of summarized in what I ended up sending to him. But overall, as we discussed, there could very well be some disc or nerve root involvement. But most importantly, we understand that this actually has a very good prognosis to recover and heal through thoughtful rehab and time. And the biggest things that give me confidence are that we're able to rule out any serious red flags that would warrant medical urgency. And we were able to identify a few key patterns that will help guide decision-making in this early phase of the rehab process. Overall, we do want to try and put up some good guide rails in the short term with both your training modifications, but also in your day-to-day and how you're interacting with your environment. So once we can get these things to calm down, we can really start reintegrating and training more like you're used to. So at least for me, like, and this is just time out from what I was telling him, like when I'm looking at these things, at least my framework for thinking about managing low back pain, especially radiating low back pain, is trying to identify simple buckets of what their triggers might be. So for example, is there a directional preference? Is there a high neural tension trigger? Is there a high static position trigger? Is it just being vertical versus being horizontal? Like, these are some of the main buckets that I tend to think about. And if there's like a clear cut slam dunk where it's like, okay, this person's really high neural tension sensitivity, then that's probably a good pattern to key in on that might make sense to modify in the short term. And so if we keep going, so what I explained to him, and I wrote this out, so in the document that I send you guys after, there's more detail here, but just to kind of explain how I might explain to him off the dome. So we know in the short term, none of these things are inherently bad, but given the volatility of some of the kind of nervy symptoms that you're having, I think it might be worth putting up some of these kind of guide rails in the short term, just to make sure things are really moving in the right direction. So I think the biggest thing we identified was some of the, what we kind of call quote unquote neural tension, AKA the nerves in your body are a little bit sensitive to stretch right now. The one thing that we've kind of learned over time is that sometimes when nerves can be sensitive, stretching them excessively or being in prolonged positions where they're on stretch can be a little bit sensitizing. So if we're just a little bit cognizant of, like, for example, when you're sitting during the day, maybe you put your leg up on a stool or you keep it bent instead of straight out. When you're driving, maybe you're keeping your leg bent instead of straight out. When it looks like you're training, we might just chill on hinging for the first few weeks, because at this point in time, it might not be like, could you do it? Sure. But I think if we kind of let things calm down, we'll be able to access and get into that in a sooner time frame. So I think that would be a good starting point. The next thing we identified is stagnant postures tend to be a little bit of a trigger for you. And this is pretty common for folks coming in with low back pain. And this doesn't need to be overcomplicated, but I think the biggest thing you can do is just, we'll go over a couple of different little quote unquote movement snacks, things that you can start to dose in throughout the day. They don't need to be anything intense, just things to break up so you're not spending too long in any one position. And then lastly, end ranges of extension and flexion also seem to be a bit of a trigger. So we are going to start to expose you to that, but we are going to be like, if you're continuing to bench right now, might not be worth trying to get into that extension position if that's bothering you. We might do like a feet up variation, something that's going to keep you a little bit more flat and tolerable. And then again, we'll work towards getting into that as soon as we can. But I think if we can put these kind of constraints up for like 2 to 3 weeks and kind of start to nudge them down, I think we'll be in a really good position to get training again. In the meantime, we'll look at all the things that we can keep doing. So your movement snacks. So these are things that I gave him: cat cows, rock backs, hamstring flossing. So it's my assessment, but it's such an easy thing to do for people. It's such an easy way to get them building implicit confidence in their ability to move their back in a way they thought was provocative. So if he was intolerant to flexion, okay, these are really easy things to do to start getting him moving. And they're also kind of had that like dural, neural, flossing glidey effects. The cat cows, rock backs, and hamstring flossing accomplish all of those things. But it's more about just saying, hey, in the short term, static stretching, not necessarily my favorite thing for this particular context. Let's try to keep these motions more flowy. And just remember, I wouldn't necessarily recommend pushing past pain per se, but let's definitely the analogy. Now, I don't love using it all the time because of the imaging it can conjure. So I'm careful about how I word it, but I try to word it as, imagine you're cooking and you're approaching the stovetop. As you start to approach the stovetop and you might feel some gentle warmth, that's kind of where I want you to stop with your symptoms right now. So when you're doing some of your cat cows or your hamstring flossing and you feel a little bit of that gentle symptom come on, that's a good place as like your threshold. So let's leave it there for now, make sure we're honoring that, and we'll monitor how your body's responding, and we'll try to progress those things as we go along. I try to keep these pretty low set, so like one set at a time, 5 to 10 reps, something easy peasy that you can knock out in a minute and do 2 to 3 times a day. So I'll just read this out real quick. So as we spoke about, the goal in this phase is to keep your training hard, but also being smart about modifications. Given the fact that symptoms have been somewhat inconsistent, I prefer to just lean more conservative, put guide rails up on the movements that have a higher probability of triggering symptoms. So in the short term, the only 2 main things I would place on hold would be hinging based exercises and benching with an arch. Otherwise, you can pretty much feel free to train your heart out. I spoke with his coach later that day, so that was a nice little contextual factor to leverage, that I would be collaborating and reaching out to make sure that we're on the same page with the program. So kind of the wrap up spiel, look, I think you're going to do great with recovery, but just knowing it's a process with ups and downs, so long as it's moving net positive, we're good to go. The key thing I would love to see changing in these first 4 weeks would be decreased frequency and intensity of both the lower back pain and nerve symptoms, improve range of motion tolerance for lower back into all of the ranges, getting back into more consistent training routine. So that was more or less kind of the email spiel that I gave him. And the one other thing that I touched on in person was just talking about the timelines. So understanding and being like, look, man, there's actually a lot of really good things in your favor. You're already moving a ton. You have a really rich activity history. These things, like you've done it in the past where it generally resolves. Like you've had cases of like this and they resolve. Maybe not this intense, but the good news is that you're already starting to see a decrease in the intensity. Maybe the oral steroids helped, maybe not, but things are already trending in the right direction. And we do tend to see that folks make a pretty good recovery even within as soon as 12-week window. So I think things are looking really good. We have a lot to be optimistic about. We'll monitor all the symptoms to make sure things are going well. And I did tell him that my personal opinion was that I did not think imaging was necessary at this point in time. I validated the fact that it's totally reasonable to want to know what's going on, but I just tried to express to him that the thing is that even if there were to be some sort of disc pathology or nerve root pathology, it would not radically change the way that we're going to manage this, because we've identified key patterns of things that he was sensitive to and or triggered from. And so that's going to be so helpful in informing this and knowing that majority of these cases tend to resolve and surgery is rarely indicated, but knowing that we can always have that option if things were to radically progress in the other direction. So that was communicating the plan. So I saw him 10 days later. Here are parts: an overall decrease in symptom intensity and frequency. He was able to really embrace the short-term modifications, the movement snacks, the positional considerations. He said he was able to get to his 2 best training days over the last few months. He squatted over 300 pounds with no symptoms. Let's go. But also literally humans are fucking crazy. And it just is so insane to me how like you could be so sensitive in one position, but be able to tolerate a 300-pound squat. And that's where I'm just really grateful for this community of providers, because obviously we're not trying to be reckless assholes and just be like, oh, go load, whatever, it doesn't matter. But at the same time, like, if he's feeling good and it's not creating any symptoms, like, live your best life. And it just is kind of scary to me thinking about someone like this going to care with someone who's maybe not informed to this stuff and being like, oh man, no, like squatting 300 pounds, you need to shut it down, because that would probably be pretty common that would happen. And he was just super pumped, super optimistic heading in. So basically my plan for the first session was I wanted to find an entry point to some tolerable hinge exposures. I wanted to find an entry point to some tolerable lumbar extension exposures. And I wanted to find a entry point to tolerable intra-abdominal pressure, because that was, remember, his mechanism of injury was a cough. So he definitely does have some sensitivity to the bracing. It's just that he wasn't really lifting heavy enough, besides for the squat day where that was really a constant trigger. So the session structure, I tried to keep pretty simple, but warm up quickly, cat cows, rock backs, hamstring gliders. So the tall kneel hinge with band tension for someone that's not tolerating hinging or has high neural tension. I love this variation because it's super simple. And it can get them starting to hinge again in a way that takes a ton of slack out of the posterior chain by getting the knees out of the mix. And he loved it. We tried it and he was like, oh my God, this feels so good. He was like getting a glute pump. He was like, this is sick. We did, again, like a back elevated bridge. My mind was like, if I can get this dude hinging in a way that's going to be less provocative and he can start to build some confidence with the movement, we can start to condition his body's nervous system, posterior chain for these things. Hell yeah. So that was my intent with the first circuit. My intent with the next circuit was doing some back extensions to neutral just to see how he would do. And I was a little skeptical about that, but it actually felt pretty good. So that was another good one that we put on the trainable menu. Wall sit with floating heel. That's just so we're not doing literally all back things for an entire session, just showing him another option that he can get after some quad burners without doing heavy squats. Tall plank into bent knee downward dog. So this one is kind of another like weird hinge exposure drill that I like. So for people that are hinge intolerant, you can use the knee as your dial to kind of like finesse how much posterior chain tension you want. So this is another way that like you can keep the knee super bent, but he can start to get a little bit of hinge exposure. So I like that one as a more kind of dynamic, flossy type of thing and hinge exposure drill. And then lastly, just an anti-rotation press out, again, with no intent other than just getting some intra-abdominal pressure. He also felt unilaterally like something was off. So giving him a unilateral biased kind of core movement, quote unquote, was more to train some of this intra-abdominal pressure tolerance rather than like core stability and like this being a deficit that was hindering his progress for whatever reason. Yeah, so that was week 1, and I'm happy to say last week was week 5, or 2 weeks ago was week 5. Dude is like, it's always amazing when things go exactly to plan. And that's why these cases are so fun, because on average, I would say, not always, but I'd say on average, people coming in with subacute low back pain tend to get better and tend to do really good. And you don't necessarily need to arbitrarily baby them, but there's a time and place for putting up the guide rails and then push them where you can. And so basically the progression that we did was week 2, he was feeling good. Like he wasn't really having any neural symptoms anymore. Like frequency and intensity of the low back pain was way down. So we actually started with an elevated sumo deadlift off a 5-inch block. And he tolerated that really well. And he was so amped. He was so excited. The smile on his face was, well, actually I couldn't see it, but because we still wear masks in Boston, but you could sense it. It was really good. And then week 3, we moved down to a 2.5-inch deficit. And then actually I lied. We did 2 weeks of this week 1. So this was week 3, we did the 5-inch. Week 4, we did the 2.5-inch. And week 5, we just pulled from the floor, worked up to around 185. Dude hasn't pulled from the floor since like December or like around Thanksgiving. And he was just ecstatic. He felt good. Things are going really, really well right now. Kind of spoke about like, just like there's, still want to be reasonable with how we're progressing things, but I can send you guys, I have the full progressions of what I did for the first 5 weeks, because there were some other little things that I kind of finessed in and out, but more or less, I think that's it. So I want to talk about this. Sorry, I was reading Shelby's comment and trying to communicate and my brain froze. So let's go like 10 minutes, and also just saying, just little low key special announcement at the end. So, but we're going to wrap up in like 10 minutes. So let's just do open Q&A, questions. Feel free to roast me. And let's just chat about this case.
I had a quick question about the symptoms and then progressing the program.
Yep.
When are the symptoms too much for him, you think? And when do you think it's good to go? And when do you think it's time to slow down the program and regress it? Like, what are some things you look for?
Yeah, so timeline is one. Like, this dude, remember, he came to me at 4 weeks and he was already on the downward in terms of his symptom intensity. And he was off of a 10-day dose pack of steroids, and I didn't see him for another week and a half. So by the next time I saw him, he was already 5.5 weeks into his timeline. So based on how he was doing, that's going to shift my confidence to kind of nudge and push a little bit more based on just the overall progression of how these things tend to play out, and also the stability of symptoms. So how volatile is it? Is it something that's like literally super inconsistent and flaring up still like every other day? Or has it been consistently now, for the last 10 days, it's been consistently pretty good or moving in the right direction? So those are the things that would definitely inform that. If it's still earlier on and I was seeing him like in those first few weeks, we probably would have been a bit more conservative with how we were progressing things, if that helps answer your question, Kiefer.
Absolutely, thank you.
Yeah, so Anna, just to answer your question, so prescription for home was basically the movement snacks, because I didn't see him for that first 10-day period where I was like, dude, you're still in the time where like the body is going to do its thing. Like, I need to get the hell out of the way. So here's some of the modifications for your environment that I think would be super helpful. And then stick with the training days that are feeling good. Like, he was still going to the gym 3 or 4 days a week, just doing GPP. So I'm like, we don't need to overcomplicate it. Like, do your GPP, do your movement snacks, some of the other movement modifications, and that was it. That was it. He was only coming in once a week.
I know you mentioned that you were talking to his trainer, and I was just kind of curious, as you were kind of moving through those next few weeks, did you make specific recommendations about like changes in his programming volume, or did you kind of leave that up to his trainer?
Yeah, I did. So I can send over that email. I'll just add what I sent to the coach too. But it was basically just like he was doing lower in almost all of his days. And so one of the biggest things that I recommended was just trying to get into the habit of like, let's for now keep the lower days, and make sure that we're having at least a full day of recovery before training it again. So that was one of the biggest modifications that I recommended to his coach, was just how he was dosing in the lower body movements, and keeping it to like 3 days a week for now, and getting after it with upper body stuff. I'm sorry, is it Micah or Mika? Micah, okay, cool. So for the bench, it was the extension. So we did, yeah, he was doing floor presses, he was doing feet. He's short, so he was doing feet on like a box too, but he was still getting into that extension position. So we just went with like either a totally feet up. We talked about doing a Larson press, which is basically just long legs. But for someone with neural tension sensitivity, Larson press wouldn't be my go-to, because that's putting them in like that sort of extension position. So we went with feet up, bench, and floor press. Ryan, you had mentioned that plan of care would change a bit. Oh no, I said would not have changed. Like it likely would not change, even if there was disc or pathology on the imaging. Sorry, we can go back. There's a built-in stenography by doing this on record. So we'll go back to the tapes. Ryan's about to put me on this smear campaign on social media.
Okay, I must have heard you.
You're good, bro.
Real quick, when you're going about ruling out red flags, how do you prefer to do that? Are you like actually asking like, all right, I'm just going to run through this list of questions, or is it more so that you're just kind of gleaning it from the things that you're telling you and kind of raising your suspicion or lowering it and then diving deeper if you need to?
Yeah, definitely more the latter. Like he was coming into me in that 3-week time where like he clearly responded well to, and again, this is what's crazy. I don't want to post hoc reason. Did the steroids help him? Was it just time? Who the hell knows? Maybe it was a combination of both. But he was getting better, and things were moving in the right direction. There was no crazy sensory deficits. There was no crazy motor weakness and myotomal. There was no reflex absence. So they're just like, and his general disposition and vibe, there was nothing that was too alarming. He was sleeping well. So you're kind of just reading the room and getting an idea. Obviously you're asking some of the big ones, but I'm not necessarily going through that whole list.
Zach, how did the abdominal inter-abdominal pressure goal progress? Like, was there a lot of therapy on your end for that, or just because he had the experience of being a powerlifter, he kind of figured it out on his own?
Yeah, he kind of figured out, actually, my education was like, we need to learn how to do low threshold bracing, because everything he did was like super high thresholds. And I'm like, bro, we're literally doing a super clam right now. Like, it's all good. Like, but you have to remember, he's coming from a very biomechanical kind of philosophy of pain, where it's like, his understanding was that like bracing at full intent was like necessary for a lot of the different movements that he was doing. So I tried not to feed into it or pay too much mind, but kind of just give him different movements that would train it like implicitly, so to speak. Micah, can you talk a bit about how you manage your own emotions around seeing a patient with radiating low back pain? Like, how would new Zach versus now Zach react? Yeah, so I think the quote that comes to mind is, a fearful physio makes a fearful patient. And I know that my body language and my implicit posture in these cases was definitely fearful, anxious, like obviously not like trying to put on a good front, but I just didn't have the reps or the experience or knowledge that like of low back pain. Because when I graduated, things were still very, very much biomechanically dominated in terms of the paradigms. So I was way more caught up on like disky things and things like that. So I was pretty shook, where now I'm like, I'm definitely not coming across as like a, I don't know if any of you watch my nihilism video, that's absurd, but I'm not telling them to basically fuck off, that they're going to be fine and dismissing their concerns. I'm saying, look, absolutely. Like, I totally can understand how this is like super terrifying. Like, I would probably be pretty shaken up too, but I'm telling you, like, based on what we know, like, and based on how you're doing, there's really so much to be optimistic about here. So I think it's just, as time goes on, getting some of those successful cases, you can gain some of that ability to be a little bit more implicitly confident and explicitly confident with how you're managing it. How did he respond to not having a hard diagnosis, since that was his goal, and his reaction not having imaging? Yeah, he was a little bit like, he was like, no, this all makes sense. It's all good. And we spoke about it. I'm like, look, dude, like, I'm not saying that there can't be some sort of like disc pathology or a nerve root injury or something to that. But I'm just telling you that even if that were the case, it would not radically change how we're going to manage this for X, Y, and Z reasons. So we kind of acknowledge that there could be, but just not saying that, you know, it had to be there or whatever. But that was just something that we, still kind of work through, because he still wants to get imaging. I'm like, dude, you're literally deadlifting from the floor, like pain-free. Like, why do you, like, now I'm giving him shit for it. But yeah. And sometimes I will talk about the negative prognostic factors associated with getting imaging for low back pain, but you have to read the room with that, because you don't want to come across as dismissive or downplaying that if it's something that's super important to them. So I try to just empathize and agree that like the reassurance and peace of mind would be nice either way, even if you know it wouldn't radically change the way it's going to be managed. Can you speak to how you manage the patient's biomechanical based muscle quirk pain beliefs? I struggle not to clash with these people and communicate my approach, which is very different. Yeah, I struggle too. I actually shared this shout out in the CALU Plus squad. I shared this as something that I still struggle with, where people are coming in, is like, no, like I can't feel my left glute during this, and like my left lat doesn't fire during this. And then you like watch them do it, and like you see the muscle contracting, and you're like, like not quite sure how to navigate this situation. It's tough. Sorry, Peter, I don't have a great answer for you. I told him that I would be more than happy to kind of go through a more thorough screening process to make sure that we're like, do we have full range of motion at the hip joint and like the scapulothoracic joint? Like, we can go through some basic screens and see if there's any opportunities there to improve some of these things, but trying not to get too caught up on it. Any other questions or final thoughts or anything like that?
If the patient had been someone who didn't get better, or like it did end up being really serious, would you like change your approach and how you managed it?
Yeah, 100%. Especially like if it's, well, first, if it's progressively worsening and they have ridiculous symptoms, then I would say this probably warrants some imaging. Like, let's go get a workup and see. Like, if it's like a day of it, like if this is a new trend, if like over another week or so, it's progressively worsening, I definitely think that warrants getting more of a medical workup and seeing what the hell is going on. Because they're like time and place for things like steroid injections or even surgical interventions. I mean, we had someone near and dear, my soon-to-be sister-in-law, had radiating low back pain, and we're like, it's going to be good, things are going to be fine, majority of people get better on average in 12 weeks, and like hers did not get better, it got worse, and she ended up needing to get surgery. And then the surgery didn't even work, she ended up re-herniating and having ridiculous symptoms and needing to have another surgery. So it definitely happens, but that's why you just need to be transparent and make sure you're not speaking uncertainties, and make sure that you're going to be monitoring things as they go along, and you'll change course as you need to. But at least for now, on average, we tend to see things play out like this. Cool. All right. Any final questions before it hits 9:10? Autumn asked, at what point will he be done with PT since he's currently deadlifting from the floor without pain? Yeah, we're probably just going to do another couple of weeks once we start to get more up into kind of his like, 70, 80% deadlift numbers where he's feeling more confident. And that's a Quinn point right there, where it's like, I did not do a good job of establishing like, what does done look like for you? Like, when does PT end? So that would be a good thing for me to do. So I'm going to do that. And we're going to talk about that, but live and learn. Cool. All right. Well, I had fun doing that, and I hope it was helpful for all of you. And that was super fun. We have a great crew. The last thing I'm going to say is shout out, because I see some CALU Plus people in the building. So I appreciate you being here. Shout out. We've been having a lot of fun doing more of this clinical mentorship a little bit more intensively. We run the mentor calls twice a month. It's been a great little crew and community going. And we're really trying to grow it, because honestly, that's what's helping us keep all of this all sustainable. And it's just a great squad. So what we're going to be doing for this week, I know if some of you are on the fence about it or familiar with about it, we are going to be just running a nice little offer for $50 off the annual. So if you're thinking about it and you haven't done it yet and you want to, just shoot me a message after, and we would love to have you in the mix. It's honestly been a really great squad. So that's all I'm going to say about that. But either way, we greatly appreciate this entire community. Thank you guys. This was an awesome, awesome squad tonight. And it makes us super happy to know that there's 50 plus clinicians going out and providing some awesome, awesome care for their patients. So that's all I got to say about that. Peace.
Thanks, Zach.
Later, guys.